नमस्ते बिटिया, हमेशा खुश रहो बिटिया। I am Dr. Bharat Sharma, Assistant Professor, Department of Pathology, Faculty of Homeopathic Science, JAYOTI Vidyapeeth, Women's University, Jaipur. Today's topic is meningitis. Meningitis is inflammatory involvement of the meninges. Meningitis may involve the dura called py- pyome- pachymeningitis or the leptomeninges pyometer or arachnoid termed leptomeningitis. Pachymeningitis is invariably an extension of the inflammation from chronic suppurative otitis media or from fracture of the skull. An extradural abscess may form by suppuration between the bone and dura mater. Further spread of infection may penetrate the dura and form a subdural abscess. Other effects of pachymeningitis are localized or generalized leptomeningitis and cerebral abscess. Leptomeningitis, commonly called meningitis, is usually the result of infection but infrequently chemical meningitis and carcinomatous meningitis by infiltration of subarachnoid space by cancer cells may occur. Infectious meningitis is broadly classified into three types. First is acute pyogenic meningitis. Acute pyogenic or acute purulent meningitis is acute infection of the pia arachnoid and of the CSF enclosed in the subarachnoid space. Since the subarachnoid space is continuous around the brain spinal cord and the optic nerve, infection spread immediately to the whole of the cerebrospinal meninges as well as to the ventricles. Etiopathogenesis. The causative organism vary with age of the patient. First is Escherichia coli infection is the common in neonates with neural tube defect. Second is Haemophilus influenzae is commonly responsible for infection in infants and children. Neisseria meningitis causing meningitis is in adolescents and young adults and is causative for epidemic meningitis. Streptococcus pneumoniae is causative for infection at extremes of age and following trauma. Gross appearance: pus accumulates in the subarachnoid space so that normally clear CSF become turbid or frankly purulent. The turbid fluid is particularly seen in the sulci and at the base of the brain where the space is white. Microscopic examination shows there is presence of numerous polymorph nuclear neutrophils in the subarachnoid space as well as in the meninges, particularly around the blood vessels. Gram staining reveals varying number of causative bacteria. Now, clinical features and diagnosis. Acute bacterial meningitis is a medical emergency. The immediate clinical manifestation are fever, severe headache, vomiting, drowsiness, stupor, coma, and occasionally convulsions. The most important clinical signs is stiffness of the neck on the forward bending. The diagnosis is confirmed by examination CSF as soon as possible. The diagnostic alteration in the CSF is in acute pyogenic meningitis are as under. First is naked eye appearance of cloudy and frankly purulent CSF, elevated CSF pressure above 180 mm of water, polymorph nuclear neutrophilic leukocytosis in CSF between 10 to 10,000 milliliter, and raised CSF protein level higher than 50 milligram per deciliter, decreased CSF sugar concentration lower than 40 milligram per deciliter, and bacteriologic examination by gram stain or by CSF culture reveals causative organism. Now, second is acute lymphocytic meningitis, viral or aseptic. Acute lymphocytic meningitis is a viral or aseptic meningitis, especially common in the children and young adults. Among the etiologic agents are numerous viruses such as enterovirus, mumps, ecovirus, cocci- coxsackie Epstein-Barr virus, herpes simplex virus, 2 arthropod-borne virus, and HIV. However, evidence of viral infection may not be demonstrable in about a third of cases. Gross appearance shows some cases show swelling of the brain, while others shows no distinctive changes. Microscopic examination, there is mild lymphocytic infiltrate in the leptomeninges. Clinical features and diagnosis. The clinical manifestation of viral meningitis are much the same as in the bacterial meningitis, with features of acute onset of meningeal symptoms and fevers. However, viral meningitis have a benign and self-limiting clinical course of short duration and is invariably followed by complete recovery. Their CSF finding in viral meningitis are as naked eye appearance of clear or slightly turbid CSF. CSF pressure may increase about 250 mm of water. Leukocytosis in CSF. CSF protein usually normal or mild raised. CSF sugar concentration usually normal or CSF bacteriological sterile. The third is chronic meningitis or tuberculous or cryptococcal meningitis. There are two principal type of chronic meningitis. First is tuberculous meningitis, occurs in children and adults through hematogenous spread of infection from tuberculosis elsewhere in the body, or it may simply be a manifestation of miliary tuberculosis. Less commonly, the spread may occur directly from tuberculosis of the vertebral body. Second is cryptococcal meningitis, develops particularly in debilitated or immunocompromised person, usually as a result of the hematogenous dissemination from a pulmonary lesion. Cryptococcal meningitis is especially an important cause of meningitis in patients with AIDS. Gross appearance shows in tuberculous meningitis, the subarachnoid space contains thick exudate, particularly abundant in the sulci and the base of the brain. Tubercles 1 to 2 millimeter in diameter may be visible, especially adjacent to the blood vessel. The exudate is cryptococcal meningitis is scanty, translucent, and gelatinous. Microscopic examination shows tuberculous meningitis shows exudate of acute and chronic inflammatory cells and granulomas with or without caseation, caseating necrosis and giant cells. Acid-fast bacilli may be demonstrated. Late cases shows dense fibrous adhesion in the subarachnoid space and consequent hydrocephalus. Cryptococcal meningitis is characterized by infiltration by lymphocyte plasma cells and occasional granuloma and abundant characteristic capsulated cryptococci. Clinical feature and diagnosis. Tuberculous meningitis manifests clinically as headache, confusion, malaise, and vomiting. The clinical course in cryptococcal meningitis may, however, be fulminant and fatal in a few weeks, or be indolent for months to years. The CSF finding in chronic meningitis are naked eye appearance of the clear and slightly turbid CSF, which may form fibrin web or standing. Raised CSF pressure above 300 millimeter of water. Mononuclear leukocytosis consisting mostly of the lymphocyte and some macrophages. Raised protein content and lowered glucose concentration. Tubercle bacilli may be found on microscopy of the centrifuge deposit by jet and staining in tuberculous meningitis. Pathognomonic capsulated cryptococci with a halo are appreciated in Indian ink preparation of CSF in cases of cryptococcal meningitis, while the capsule in pattern demonstrated by mucicarmine stain. This session is powered by Digital Version 2.0, Jyoti Vidyapeeth Women's University. I hope you all enjoyed this session. If you have any query, please mention it in comment box. Thank you.